طيب، السلام عليكم. مرحبا بكم المرة الثانية. اليوم 5/8، أكاديميك دي تقريبا السادس أو السابع. والليلة بنتكلم عن how to approach patient with syncopal attack. هي واحدة من ال common presentation في ال emergency department. و it is syncope. ممكن الناس يشوفوها حاجة عادية، it's just syncope، لكن فيها كلام كتير. وهي ممكن تكون presentation ل significant and serious complication. وهي برضه ممكن تكون في نفس الوقت very simple يعني. Anyway، الليلة هنتكلم عن ال approach to syncopal attack and how you can approach patient with syncopal attack in emergency department. دكتور محجوب العبيد هو emergency medicine specialist batch 5 working now in Rashid hospital. This governmental hospital in Dubai, Imarat.
Hello everyone. Yeah, ready to start? Approach to Syncope in emergency department. I will be with you, inshallah, Mahjoub Abed, batch 5. This will be an interactive session. So we will go through the approach of Syncope in emergency visits. Let's start. So let's refresh by asking few questions, and this not for answer, just to like warm up, and just ask anyone if he able to read these questions, they get an idea about what we are facing in emergency department. So the first thing that you ask yourself when you about to approach a patient presented with syncope, when a nurse or junior colleague to ask you that I have a patient had syncope, so I need you to assess him with me. What is ideas, or what is your thoughts and question to yourself before you approach that patient? And the other thing, and the other question, do you think syncope is challenging for emergency physician to diagnose or not? That's what we're going to see now in this lecture, and we will go through the introduction and the causes of syncope, then the clinical assessment about the history, examination, and investigations, and then about the risk stratification, and we will have a couple of cases to discuss together. So regarding the introduction, syncope is not rare. It's quite common, 3 to 5% of emergency visits. So like every week, you may face a patient with syncope. And it's quite common in elderly patients. So it's jump up to 6% in elderly patients. And most of the study that's showing that syncope has multiple, the patient will come with multiple episodes, like 30% of patients. It will not be like one episode, always like multiple episodes. And as the known said, it's like the prognosis change, and from according to the underlying cause and the reason. That's what we will say soon. So the first question that we will start is, what are your goals when evaluating a patient with syncope in the emergency department? So while you are approaching a patient with syncope, what do you want to to reach after you assessing the patient? What is your goals? So anyone can share any ideas?
After stabilizing the patient, will check for the underlying cause.
Okay, so underlying cause, that's the first thing that you think about. What else?
She said also ما عجبش stabilization of the
Stabilize,
patient.
yes, that's the most important part. Stabilize the patient. But do you think the diagnosis is a goal for to reach the final diagnosis? Is it a goal for emergency physician to reach in a syncopation?
No.
Yes, all right.
لو في أي حد عايز جاي برضه ممكن أفتح المايك يتدخل برضه. I think ميرفت في المسك قالت برضه no يعني no need to diagnose patient with syncope.
Yes, it's no need. It's not necessary to reach a diagnosis because most of patient they will not reach a diagnosis in the emergency, even if being evaluated by a cardiologist or another department. So this is what our goal is. The first thing is to distinguish between the serious and non-serious cause of syncope. That's the most important part here, because as we will see that we have like simple or low risk causes of syncope, that the patient can be like discharged safely home, and we have a very serious causes that need more evaluation, maybe admission, maybe an urgent interventions. And the other thing, as Merva said, to provide interventions in high risk patient, so stabilize the patient. If and you found syncope or loss of consciousness as a part of the sign of instability in ALS algorithm, or in most of the algorithms that you found, it's a sign of instability. So that's most important. And the other thing is to avoid unnecessary investigations, because many of syncopes they have like simple underlying causes. No need to like order many of lab tests and imaging, and we will see in the cases. So cause of syncope, as we said, diagnosis is not our target in syncope patient, because 50% of patient they will not get a diagnosis in the emergency department. The common cause of syncope is cardiogenic syncope, or vasovagal, which is low risk, cardiac, which is high risk, orthostatic, and other are low risk. We will see which is which in the coming. So regarding the clinical assessment will include the history, examination, and investigation if needed. So regarding the history, when you approach the patient, history is the first thing to do, right? So the patient will not tell you that I have syncope, right? He will tell something else, and from your experience, you will distinguish which it a truly syncope or not, because there is many other condition like presented similar to syncope, like what we call near syncope or drop attack, and seizure can mimic syncope, and also vertigo, hypoglycemia. There's many differential diagnoses for syncope, the word itself from the start. So when they say the syncope, how would you define syncope? So what the question that you will ask the patient to reach if it's syncope or something else? And that's I think this is very first point, and it's very crucial to start right in the approaching patient with syncope. So anyone can tell what is the question that you will ask the patient, or what is the definition of syncope?
Very important to differentiate this syncope from loss of consciousness, and also you have some sort of confusion, delirium, a lot of concept here. So it is very important for you to know about the definition. If you define syncope in a correct way, that means you understand what is syncope is. So we need someone to just to define us what is syncopal attack.
Um, okay. السنكوب attack عشان تديفاين فيها 4 elements. It's acute and it's brief. معاه loss of postural tone and بعديها في regain of the baseline neurological status.
Yes. Yes. That's syncope. That's the definition of syncope, of course. You will ask the patient, what's happened exactly? Are you aware with what's happened? Did you lose your consciousness totally or not? And for how long that's happened? And like, did you receive any treatment or anyone give you anything before you regain your consciousness? So, definition of syncope, as you said, is a transient loss of consciousness due to a temporary reduction in the blood flow to the brain, which fully neurological recovery without any intervention. So the patient welcomed that. They said like all of a sudden I feel like I blacked out. I'm not aware with what happened to me. Just I found myself in the ground for 2 minutes or 1 minute, and then I woke up with like I can't remember what happened exactly, and yes, and I get fully conscious after that. So that's syncope. Okay, so that's 2 minutes or 1 minute. It's very important to like ask few more question to see if it's serious or not. So that will be like the other part of the history. And just to like highlight it here, history can be in one of the exam station. Like they will give you like this short scenario here. A 21 years old male has presented to emergency department following a brief episode of syncope. Please take history and outline your management steps. This can be like an like exam station, or in real life that can happen. Like a nurse come to you that this patient had syncope or loss of consciousness. So you have to take history. So what is your approach in taking history? Do you have like a frame to like ask a question so you cannot forget anything, or you just going to ask? So in this, I can tell that there is like a frame, we called it like for loss of consciousness in general, and syncope one of them, that it can ease for you to take a history. Like we divided the history to pre, during, and post. So pre-events, what happened, during events, what happened, post-event, what happened. This is all about this 2 minutes or 1 minute. So pre-event, you will ask, like you need to reach what lead up to this episode by asking the predisposing factor, if there is any, like if the patient sitting in a crowded or warm place, and like he like had prolonged standing or this happen after a meal, or patient while in the bathroom, opening his bowel there, or like he's doing exercise or whatever. So you will ask, what are you doing at that time? Exactly. This is first thing to ask. After you establish this is syncope, of course. Then you will ask the patient, if it's not clear from the first question, are you sitting or you are standing, or what your posture exactly? Because this is very significant. Later on, we know which is low risk and which is high risk regarding these questions. The other thing, the activity, what are you doing? As I told you, he's in rest, he's exercising, what he's doing exactly. And associated symptoms like chest pain, breathlessness, palpitation, and if there is any prodromal. So from this, we will see. Is it a high risk or a low risk? For example, I will give example and you tell me, is it a high risk or low risk? A patient, yes, he was standing for a long time in he's doing shopping, for example, and it's like a bit crowded and it's warm and he's standing there for a long time. And all of a sudden he feel like loss of consciousness for a while, and then he woke up. So what do you think? Is it a low risk or high risk?
Low risk.
Low risk.
Or why it's low risk?
Vagovagal attack.
Yes, because it's most likely reflex. Another patient came with like he's doing exercise and like he's, for example, working gym, and just he's all of a sudden had loss of consciousness, and he found himself in the like surrounding by people for like 3 or 4 minutes. Then he woke up, and you ask him before that he had like sudden palpitation. Is it a low risk or a high risk?
High risk.
High risk.
The cardiac causes.
Yeah, this high risk, maybe it's most likely a cardiac cause. We will see this in the coming slides. So this about the pre-event. From the pre-event, you start to recognize this is a high risk or low risk, right? You didn't complete your history yet, and you didn't do an examination yet, and you didn't order any like test, no labs, no ECG, nothing there. And you start to know is it a low risk or a high risk. So I think it's simple. So going further by asking the question, the history, you will come to the during the event part. So during the event part, I think that you're not going to ask the patient because he's unconscious at that time. Rather, you will ask the witnesses or what the witness tell him, right? So you will ask him, is it like witnessed by anyone or not? If he said yes, what they tell you? What are they telling you, or what did tell you exactly what happened? So you will ask about if there is any abnormal movement, for example, any cyanosis or pallor, that he became pale or not. And also you will ask about the duration, for how long. That's very important. Because here, I think this part will differentiate between the neurological syncope and the other part. Neurological syncope may be a fit or convulsion, for example. So if the witness said yes, there is abnormal jerky movement in the limbs, so most likely maybe it's a brief convulsion, right? If he said no, the patient like looks cyanosed or look pale, like a dead, he's not moving for 2 minutes or 3 minutes, that's maybe most likely the other causes, and maybe cardiac also. So here, this part during it will tell us most likely it will like differentiate between the seizure, the convulsion episodes from syncope. And the other part is the post event. So post event or the recovery phase. So you will ask the patient after that, after you gain your conscious, did you feel anything like nausea, vomiting? Did you vomit, or like did you notice any like laceration or incontinence, tongue bite marks, or do you feel like fatigue for a long time? Also, this will differentiate convulsion from the syncope. And we will see that it's not 100% like differentiating, but because there is like interaction between them, as we will see. So here this is the main history. The main part in the history is history of presenting illness pre and during and post. From here you can tell is it a low risk or a high risk. Then you will carry on further by asking more questions to the rest of the history, like if there is any comorbids, cardiac problem, diabetes, Parkinson disease, any family history like sudden cardiac death, arrhythmias, any relative drug history, like there is many drugs can cause like orthostatic can cause orthostatic syncope, like beta blocker and trait, calcium channel blocker, and all the blockers. Also insulin and other medication, because this patient maybe it's like simple hypoglycemia, for example, as a differential. So here you finish your history part, and you can tell. Then you will come to the examination as a second part in assessment. In examination, there is like, I will not tell that the examination is not useful, but most likely you will not get like more information from the examination, and most of the patients they have normal examination in syncope. So I think history is more important. But anyhow, you will do the examination, mainly cardiovascular and neurological examination. In the cardiovascular examination, you will try to like identify evidence of heart failure or valve lesions. Also, definitely you will take the blood pressure, like orthostatic, to diagnose orthostatic hypotension by dropping systolic blood pressure less than 20, for example, mainly in older people. But this definitely will not prevent you to search for other reasons for syncope, because especially in elderly, syncope can happen, and maybe there is multiple causes. So don't get fooled by the simple and obvious cause and miss the other serious causes. So always like look for multiple causes, especially in elderly. So the sign you will see, it's a sign of heart failure, like the heart sounds and murmurs and all the stuff. And in the neurological examination, you will examine and you will like investigate if is it a seizure, seizure episode or syncope, by examining the tongue, examine the whole limbs, and also if it's absent, that's not exclude seizure. And also patient with vasovagal syncope, as I said, can come with urine incontinence or even convulsion type of movement. So you will do it. Hopefully you can find a murmur, for example, that will help. So the other, here you finish the history and examination, and you will have like a picture about what's going on. So not take more than like 10 minutes with the patient. Then you will come to the other part of the clinical assessment, which is you have to look for injuries, because patient fell down, he may have an injury at any part, especially the wrist, the hip, in elderly patient. Also, don't forget this because it's very important, and it could be like a major mistake if you couldn't like reach diagnosis of syncope related injuries. Also, as I said, look for more than cause for the syncope episode, especially in elderly. But the important part is increasing frequency of collapse. This suggestive for cardiac cause. If the patient tell you this like 3 times, and it getting shorter in the duration, like the first one happened 1 year, the second one happened 6 years, this 6 months, sorry, and this 3 months. So it's getting shorter in the duration. This is highly suggestive for a cardiac cause, so take it serious. Also, if exercise related syncope or exertion syncope, it's always serious, even on one single episode. That is very serious. So it can indicate in arrhythmias or structural heart abnormality like Huckamore. So here you will complete your clinical assessment. Definitely you need something to help, which is the risk stratification. There is many of risk stratification and many of rules. But I found the San Francisco rule, it's very simple and it's helpful. I will not tell you that to guarantee 100% that it's for like to discharge or to admit your patient just on these rules, rather than take it as a helper, because we will see that this rules has some minor defects. But in general, San Francisco rule has 98% sensitive and 56 specific. So what does it mean 98 sensitive? Is it mean like it's rule out or rule in the diagnosis, and how much is this helpful for our practice as emergency doctors? Anyone can answer.
98 sensitive can rule in. I think cannot rule out.
Sensitive, it can rule out or rule in.
Sensitive rule in. Specific rule out.
Anyone have any like other opinion? Well, as I said, the spin and spin, like spin specific for rule in, right? Spin and snout. Sensitive, like rolling out.
A specific rule in, sensitive rule out.
Okay, so and I think this is very helpful in our practice, because we just need to know this, is it serious or not, right? So if you had a quick checklist, like you go through all, this is they have 5, like here, what history of congestive heart failure, hematocrit less than 30, abnormal in ECG, complaint of shortness of breath, systolic blood pressure less than 90. So if you take this, oh no, so you have 0 score, so this low group, low risk group, okay? But if you have anyone, so yeah, this is high group, high risk group. So this will help to rule out, and that's, I think, what we need in the emergency practice is like easy criteria to rule out. So just you can use this as a symbol to like categorize your patient to a low risk or a high risk. It's easy and simple. Okay, so I think we need to practice. So I need someone to start. We have a couple of cases, and this is case number 1. Who is willing to go through this case? It's easy cases, and I think most of you like know about those cases, but like to make it here, so you can think about it while you approach patient with syncope. So anyone like want to volunteer for the first case? I think we have 3 cases. Okay, 18 years old student attend following a brief loss of consciousness while playing football. He has the previous episode of fitness on exertion, so this is not his not first. It's not his first time. His neurological examination is normal, as usual. Cardiovascular examination is normal, a part of grade 3 mid-systolic murmur, loudest in aortic area, with no radiation. So from the history, did you get enough information to tell is it a high risk or low risk? If you just like read from here to here up to here. Just did you get like confirmation to tell you is it a low risk, like not serious, or a high risk, like serious? You have to take it serious. Anyone can tell anything regarding this?
High risk due to structural heart disease, most likely aortic stenosis.
Yes, this regardless of diagnosis, we don't care about the diagnosis, right? We don't care about the diagnosis. This diagnosis can be like done by cardiologist or by anyone that doing a proper echo. Yes, we need to, because your responsibility is to admit this patient and refer him to cardiology for more intervention or to neurology or whatever, or to discharge this patient home, because this is your responsibility, right? This is your responsibility. So how to know that and how to reach a decision to admit or to discharge the patient by like risk stratify the patient. Is it a high risk or low risk? We don't care about the diagnosis. As you said,
High
yes.
risk. Yes.
Yeah, this is a high risk from the history. Yes, from here to here.
He
Yeah.
got a history of multiple syncopal attacks before,
Yes.
mainly on exertion.
Yes, that's the 2 point that the most important 2 point in the history. One is exertional, which a single exertional syncope, it's a serious. The second one is like multiple times. So those point to like cardiac cause of syncope. Let's go to the examination part. The neurologic examination is normal. So most likely this is not a fit, not a convulsion. And the other thing is that you had you hear murmur in the auscultation. Is it a high risk or low risk?
High risk.
Yeah, murmur is high risk, right? Murmur make it high risk. So in this patient, what you will do, what's your next step? He is vitally stable anyhow. So your next step you will do, that's the second part, which is the evaluation, the investigation that you will do. I need just one important in like investigation you will do.
ECG.
Yes, ECG. And in this patient, this is your ECG, for example. So
LVH pattern.
yeah, anyone can tell. This is left ventricular hypertrophy pattern. And what else you can see here?
What Parkinson White?
Like you said, left ventricular hypertrophy pattern. That's right. And here you have deep Q wave, right? In the inferior lateral lead. Deep dagger Q wave. So this point to what kind of diagnosis in this presentation?
HOCM.
Yeah, most likely, right? Most likely.
Yes.
Yeah. So that's what we have: left ventricular hypertrophy pattern and deep narrow Q wave in the inferior lateral. So just from the simple thing, you don't need for like many lab tests, which will come negative all. Like I can't expect this patient have a positive troponin, and also I can't expect this patient will have like any others say. Okay. So this first case, as I told you, that you don't need for many lab tests, like any imaging, anything. It's simple. From here, you can argue with the cardiologist that this patient is high risk and need for admission, and definitely this patient um, need for echo and more treatment and follow and admission in the hospital. Okay, this about the first case. Let's go to the second case. So this is the second case. Anyone? "21-year-old male has presented to emergency department following a brief episode of syncope. Has normal physical examination and vitals. He feels fine now and wants to go home." So history is not like enough, right? There's no much detail in the history, and examination is not like helpful here. But anyhow, syncope can be just deal with, you can deal with syncope from the ECG as in this patient. Your next step will do the ECG, and here your ECG. So what do you think in this ECG?
Burgada?
Yes. So can you describe it like the changes in the ECG?
Down sloping is the elevation in chest lead.
Yeah. What we call this type 1 or 2 or 3?
Type 1 تقريبا.
Yes, this type 1.
Mhm.
So is it a Brugada syndrome or Brugada sign in this patient? And what is the difference? This is the history.
Syndrome, I think, since
Yeah.
it's just a syncopal attack, not sudden death.
Okay, let's come to this point. Brugada syndrome, Brugada sign. So Brugada syndrome, you have diagnostic criteria, which had two components, the ECG component, and the other one is the clinical criteria. You need ECG changes, and you need one of the clinical criteria. So the ECG can, the only one that you can say this is a Brugada sign is type 1, right? Which is like cuffed ST segment elevation more than 2 millimeter in more than one lead of V1 to V3, followed by negative T wave. This here, just this Brugada sign. If the patient has any one of the following criteria, clinical criteria, that means that's Brugada syndrome. And here you have to take full action. What are the clinical criteria? ventricular fibrillation, ventricular tachycardia, family history of death less than 45, has Brugada sign in any family members, like has inducible VT, had syncope, like this patient. This patient had a syncope, right? And had Brugada sign, so this is Brugada syndrome. Also nocturnal agonal respiration. I don't know what this, but anyhow, so here, this Brugada syndrome, because the patient had typical type 1 and had syncope here. So typical type 1 and syncope, this is Brugada syndrome, and here you have to take follow-up. Definitely high risk, definitely you need to admit the patient with a cardio. Okay, so let's go to case number 3. So this case, about 47 years old man presented to emergency department having a collapse in his bathroom. So the question asking, which scenario is most suggestive of cardiac syncope? You are now taking history from the same patient, and you ask him what you are doing at that time. That's the first question in the pre-event part, if you remember. So the patient tells you one of those answers, and one of those answers suggestive of cardiac syncope. Which of those? Actually, every one of those I suggest one type of syncope. If we can go one by one, we can tell. So if the patient gets syncope after cutting himself while shaving, what could be the cause of the syncope?
They're all vasovagal, no? Vasovagal
Yeah,
syncope.
the first one vasovagal, because there is like pain stimulation, right?
Yeah.
Yes. The second one, after taking a bath, woke up on the bath on the bathroom floor. So he had long standing in the bathroom, and most
This
likely it's
could be postural.
yes, this is orthostatic most likely.
Mm.
Okay, while he's shaving his neck, what could be the cause of the syncope? Shaving his neck, like he doing stimulation, right, in the
Cardiac
parotid. Yeah, no,
أو carotid.
yes, it's most likely, but it's also reflex, like hyperstimulation. Like while sitting on the toilet to open his bowels, what could be the cause?
This is situational.
That's situational, yeah. Okay, while he taking a bath, he woke up in the bath.
This is most likely cardiac, I
Yes,
think.
this
Yeah.
cardiac, because most likely he's sitting, and that's happened while he's sitting, which is one of the criteria of cardiac syncope, right? He's sitting. So yes, that's what we just said. And the first one is pain stimulation, vasovagal syncope. The second one is orthostatic. The third one is carotid sinus syndrome, we call it, while he like shaving his neck. The fourth is situational, which is low risk. The last one is cardiac, which is high risk. So here you start to differentiate between a low risk and a high risk, and a high risk, and I think that's more than enough. So going on, like this is the most serious sign you have to get. If the patient tell you just I have discomfort before the insult, breathlessness or abdominal pain or whatever, so that is a high risk. If they have during exercise always supine position, that's a high risk. If he has a sudden onset of palpitation, is a high risk. So this is your patient ECG. What do you think about it? What could be the cause? Anyone?
This looks like a trifascicular block, no? ولا bifascicular?
Go on step by step. You will
Okay,
find out.
so there's
دائما
a
الدكتور الاكاديميك اللي فات دكتور حسين وعكر قال لك في الكلينيكال في درجات، يعني انت بيقول لك اقرا الاي سي جي بيدوك درجات على الحاجات اللي انت بتعملها، فبالتالي بتقرا اول شيء بتبدا بالجنرال لوك للاي سي جي نفسها، البيبر، عندك الريت كويس، الريزم ريجولار الريت كده بتاع، حتى بعد ذاك تبدا تعلق في الحاجات يعني تتاكد المؤكد، الحاجه السهله دي بتاخد عليها درجات. بعد ذاك الدياجنوزيس او الابنورمات انت شايفها بتجيها اخر حاجه. لو قلت الابنورمات من البدايه وما علقت على الحاجات العاديه السهله الاولى دي، برضه بتكون فقدت درجات. تفضل يا لميس.
you want me to go systematically يعني.
Yeah.
خلاص تمام. طيب so the rate it's about it's a regular rate. It looks like it's probably about 100 to 150 beats per minute. We have a P wave, QRS, and the T, so يعني it's a regular rhythm. There's a left axis deviation في lead 1 و AVF. في V2 and AVR there's a right bundle branch block pattern, the RSR pattern, and V1. And the PR interval, it's not prolonged. I don't think it's prolonged. It's a normal PR interval. The QRS width is widened a bit. And yeah, so I think it's a bifascicular block.
Yeah, you're right. So yes, this is the abnormality that in this ECG showing right bundle brush block pattern as you described, left axis deviation and left and anterior fascicular block. Right, and you said the PR interval is not prolonged. What if the PR interval is prolonged?
It
Or
would,
you have any come again?
if the PR interval is prolonged, it counts as bifascicular with first heart block, or they refer to it as trifascicular block.
Yes, trifascicular block. I have two types, true and false. Like true fascicular block, if you have like Mobius one complete heart block, anything like it's true. Yeah, good. So you can complete.
Your
What's your
patient,
yeah.
okay. Your patient has no chief complaint at the moment and has normal vital signs. What is the most appropriate initial management for a stable patient with newly diagnosed bifascicular block? Immediate insertion of a temporary pacemaker, administer IV calcium gluconate, observation, cardiac monitoring, and serial ECGs, defibrillation, administration of intravenous lidocaine. I think observation, cardiac monitoring, and serial ECGs is
And
appropriate.
that's why?
Sorry?
Why?
It's the management, I think, for bifascicular block. ما متأكدة صراحة.
Yeah,
لأنه
because
try-
it's
yeah.
because what we said that your patient is stable and you like categorize him as high risk and he needed an admission. That's your job. You're done.
Yeah.
Anyhow, if your patient is not stable, yes, you can intervene. Otherwise, just observe, cardiac monitor, serial ECG, and just hand over the patient to the cardiology team, right?
Yes.
And you did a great job. That's it. No need
Yes.
to, yeah. Okay, so finally, the disposition. So any patient came with syncope and has one of those criteria, this patient should be referred to cardiology for more workup, may plus minus admission. Okay, if there is any abnormal ECG, like loss of consciousness during exertion, family history of sudden cardiac death, less than 40 or 45, with like any family history of heart problem, new or unexplained breathlessness and heart murmur, because this patient definitely need an echo, right? So for now, we just learn what is syncope. If the patient tell you, or a junior doctor or a nurse tell you that this patient has a syncope, how to confirm that from the patient by asking few questions. Then you go through the clinical assessment by asking the history, like pre, during, and post. From that, you will get if it's a high or low risk, because that's the most important goal for assessing or approaching patient with syncope. As we said, diagnosis is not our goal. And we don't order many investigation, just as you said, ECGs like an hemoglobin or hematocrit more than enough, plus minus echo. Also, examination is not that much helpful, but it can give you like a clue. Then your risk stratification is important also. And the most important part, and it's part of the decision making in emergency, which is like make you a good emergency physician, that you have a good decision making, and you will not get that unless you have a good knowledge and skills. Is to decide like where this patient should go. Either should go to an urgent procedure, for example, or should just admit for like simple treatment, or should like need a workup that may be done in the ward or in like tomorrow in the clinic, or this patient can go home simply with late appointment, or this patient can go home with just simple advice when to return back to the emergency. No one will do that except you as emergency doctor. So you have to master this, because this is your play role. Here we come to patient with syncope. The disposition is the most critical decision. And most of the exam board will like test you in this part. They will test your decision making regarding a patient with syncope, decision making in general in a patient with syncope. Like they will give you a scenario. I prepare a scenario here, and I need one of the seniors to take over the scenario. So like he can go through the history and examination with a patient and reach a final decision by the end. So we'll come to this. So this is a scenario here. Decision-making station. You are a senior doctor in the emergency department. A junior doctor has assessed a 57 years old man presented to emergency department after transient loss of consciousness while in shopping mall. The junior doctor has taken a history and performed examination and ordered initial investigation. You are now with, I think you have to ask anyone to volunteer.
يلا يا شباب. Is 57 years old man presented after transient loss of consciousness while in a shopping mall وانت معاك في النبطشية. Junior doctor has taken history and examination and ordered initial investigation, including ECG and blood test.
Yeah, the most important part here is the number 3. By the end, he asked your opinion, is this patient need admission or this patient can go home safely? And he already take history and had examination finding and other. Just you go through, ask him about like important part in the history and in the examination, and maybe lab or ECG findings or whatever you want. He will provide you with this information, and
طيب
then
نخليك انت يا محجوب، نخليك انت مثلا هم يسألوك.
yeah, I'm the junior doctor. I'm the
اوكي، يلا
junior.
يبقى كده واحد من الشباب يفتح المايك ويبدأ طوالي في السيناريو.
طيب دكتور محجوب.
Oh, Lamis. Okay, yeah. I'm the junior doctor. You are the senior, and you have just, let's say, 10 minutes. Let me just set a time.
Okay.
So, okay, you're ready?
Yes.
Yeah, okay, go.
Okay, so Dr. Mahjoub, what was the patient doing when he had the loss of consciousness?
No, okay, just sorry, just I want to show you this. Sorry. Yeah. This is your domain.
Okay.
So yeah, so you can focus in the greater part, like
In the
history
examination.
Yeah. You
Okay.
have communication skills, decision making, and management 30%. So that's what the final OSCE will be like this in the examination. Okay. Okay, go ahead.
So first we need to determine whether this was a seizure or a true syncope.
Yeah, you will going to just ask me as in real life, okay?
Okay.
If I
Type.
have any question, you are going to answer me. Otherwise, you just going through what they said here, and by then give me your. Okay, go ahead.
Okay, so was the event witnessed by anyone?
Yes, I think his family was there with him in the mall.
Okay, did they witness any jerky movements prior to the loss of consciousness?
No, they said no.
Okay. What was he doing before he lost consciousness?
Yeah, he was in the mall with his family, like doing some shopping at that time. Yeah, and yeah, I think he said that that happened while like his grandson like had some injury by a glass. So after that, it's happened to him.
Okay, so his grandson has injury and immediately he lost consciousness afterwards.
Yes.
But how long was the loss of consciousness for?
Yeah, I said 1 minute.
1 minute. Okay. Did he regain consciousness immediately after, or a bit confused after?
Yeah, he regained he became fully conscious after that.
Okay. طيب, he was just walking, no exertion of any sort.
Yeah, he just I think he was like standing beside one of the shop mall.
He was standing, okay.
Yeah.
Did he report any palpitations, lightheadedness prior to loss of
Not at all.
consciousness?
Not
Any
at all.
history of trauma?
No, he doesn't have any like pain anywhere after the fall.
No history of trauma, okay. Any past medical history?
Yeah, he said controlled diabetes and hypertension.
Okay. No heart issues?
No, not at all.
No previous surgeries done?
No, doesn't have
Was
any
this the first episode of loss of consciousness, or he's had it before?
No, it's first time.
First time. Okay. You want me to take full history or just related to the symptoms?
According to you, you are the senior here. I'm the junior.
Okay. Any allergies?
Yeah, just take anything that will help you to make a decision by then. No, it doesn't have any allergies.
Okay. And no chest pain, no palpitations, you said
No,
nothing
not
prior.
at all.
Okay. So we can review the findings and investigation now.
I did examination also.
Sorry, examination, yes. Okay. So on examination,
Yes, I did an general examination. He's look normal, conscious alert, and his vital is normal. And I guess right here the cardiovascular examination is normal. No, nothing. No murmur there. Neurological examination is normal.
okay. Neuro examination is normal. No urinary incontinence, no signs of tongue biting.
That's no, nothing.
Nothing. Okay. And GCS is 15 now.
Yeah.
Type, we can move on to the findings and investigations.
Okay. Ask me what you want.
So an ECG was done.
Yeah, ECG was done, and for me it seemed like some normal sinus rhythm. I can't appreciate any abnormality there.
Okay. Was a cardiac workup done? Troponin.
Yes, troponin negative.
Okay. And renal function normal. CBC normal.
Yes, CBC and hematocrit was normal. Both are normal. Well, hemoglobin and hematocrit normal.
Okay. Type, I don't think we need further workup at the moment. Just ECG and CBC renal function.
Okay, so what we will going to do with this patient? Are we shall we consult the cardiologist or we will just send him home?
So this patient so far is not showing any red flags for his syncope episode. It seems to be like a syncope episode. It's triggered by an emotional event. So it's safe to assume that it's a vasovagal syncope. It was witnessed. There was no evidence that it was a seizure. He has it was not on exertion, and it was only one episode. He has no history of cardiac disease or any cardiac problems. And he has no history of trauma. So we don't need to do a CT or anything. And he's not complaining of any headache or it doesn't seem to be neurological, so we don't need to do a CT. So in conclusion, there's no red flags to consider admitting this patient. So it seems like a vasovagal syncope triggered by emotional stress, and he can be discharged.
Okay, so we're going to discharge this patient. Okay, anything in advice for him?
I'd advise him that if it happens again, to come back to the emergency. If he experiences any chest pain or palpitations, to come back as well. And we can arrange for a cardiology follow-up for an echo as well.
Why?
Just to rule out any structural heart abnormalities that.
Is it needed? You said
صراحة no, it's not.
Yeah, nothing, no need.
It's not.
Right?
It was given his age. It's not needed. Okay.
Okay, so I think this patient they're asking if he's able to drive home.
One episode of syncope. صراحة I think per the RCAM guidelines إنه if it's one episode they're not allowed to drive for 6 months or something. I think. I'm not sure.
That's very serious decision, you just to like.
Okay, I would say no.
Driving.
No, I think no restriction for driving. One episode of syncope. With no red flag.
So yeah. So you did well so far. You did very well. just regarding this driving issues, I think if it's like a simple like one episode of syncope while the patient is standing, no need to restrict the driving. But
Yeah.
if he had any sign of like high risk, this patient should be evaluated first. Then he can proceed driving after that. So in this case, no need to restrict the driving.
Yeah.
Yes, so far you finished the station in 7 minutes and 50 seconds. That's good time. Very excellent. Yeah, you did well. So this is very simple syncope. I think it's simple now and it's like obvious, right? So
Yes.
yeah, so just go through history examination and few like investigation like ECG, CBC, and that's enough. No need to like do many things, no need to order many things unless it's necessary. And yeah, you can't discharge a patient even he's old and even he has comorbidities like diabetes, hypertension. He came with syncope, but there is no any high risk criteria that need to be evaluated. So you can discharge, but I think you feel, I mean, you feel the difficulty by making decision, right? To discharge
Yeah.
a patient, yeah. So you have to be like not 100% sure, but it's like this is your normal practice, so that you can be like yes, taking decision, give you junior doctor decision, so they can trust you and so on. Good.
Yes.
That. Thank you.
Thank you.
So that's regarding syncope for me. Just last slide. I'm going back. Yeah, this is the bit for.
Excuse
So,
me,
hmm?
I want to ask a question, please.
Yeah, go ahead.
Um, yeah, I didn't hear you clear about the decision of driving for this patient. I can 100% discharge him, but what about the driving?
Yeah, regarding
Thank you.
yeah, thank you. Regarding syncope, driving, if it's like a vasovagal syncope first one episode and the patient was standing at that time, so no need to restrict the driving. If there is any high risk criteria or high risk, if the patient in the high risk group or serious underlying cause need to be evaluated, so this patient should be evaluated first and be cleared. After that, he can like proceed driving.
All right.
Okay. Yeah. So let's go to our last. Yeah, this here just the failure will happen if there is more than one cause and you fail to like recognize them. If you fail to assess for any injuries, and also if you fail to recognize cardiac cause of syncope, which is recurrent syncope and exercise associated syncope increasing frequency, and that. So for now, we like almost covered the syncope. Syncope, like it's one of challenging actually. Let's come to our first slide here. Yeah. So now, if I ask this question again, what is the first thought or question that comes to your mind when a patient present with syncope? So you are about to assess patient with syncope. Now I think it's clear what you're going to ask yourself, what is your approach will be, and what is your decision will be based on, right? The second question, do you think syncope is challenging for the emergency physician to diagnose? We don't need a diagnosis. We just need to like categorize the patient. Is it a high risk or low risk? That's it. Thank you. If you have any question for me or for the noon.
Very informative والله يا محجوب. Syncopal attack assessment in the emergency department. الناس في الشات تحت أنا قلت لهم الناس يكتبوا لنا level of training just بيساعدنا كتير بعد ذاك في إنه كيف نعمل direction academic دي. Anyway, ال approach to Syncope was very informative by محجوب صراحة. interactivity كانت كويسة ودي الحاجة إن إحنا طالبينها من الناس، إنه الناس تكون more active more interactive. Anyway, if there is no any comments or questions, I think we will close the session for today. Approach to Syncope will attack in emergency department.
Okay, thank you guys. See you later.